Thank you for choosing this session on the role of CCGs and how we transform the urgent care pathway. However, certainly we don't see it just as the role of CCGs working in isolation. And with us today, we've got colleagues from our urgent care network across Lambeth and Southwark, because we certainly see this as a cooperative effort. So just to introduce myself, I'm Andrew Ears. I'm the Chief Officer in Lambeth CCG, but I also chair the Lambeth and Southwark Urgent Care Network Board. What we just wanted to talk to you about today is the work that as CCGs we're doing to enable and support change and transformation and improvement. And you heard an awful lot this morning about defining the problem, and there's an awful lot of complexity and an awful lot of how you measure it and so on. But we wanted to show you a few examples that we think have potential and have shown signs of working well around how we've been able to put some improvement in the system. So my colleagues will introduce themselves as they go along, but we're going to start off with Dr. Pat Holden, who's a GP in Southwark, and he's going to tell you about the urgent care network and what we do generally.
Okay, so I'm the GP in Southwark and responsible for the unplanned care in Southwark. And with my GP colleagues in Lambeth, we've been part of the Lambeth and Southwark Urgent Care Network, which has been in operation now for at least past 10 years, so I'm told. So the news that we had to perform urgent care boards didn't come as much of a shock to us. Our membership is wide and diverse, includes not just commissioners, but providers from the acute trusts, from the local mental health services, London Ambulance Service, the GP out-of-hours provider, as well as the local authorities who have been integral in helping us decide some of the plans that we do. As was highlighted earlier, although we cover and serve a general public in Southwark and Lambeth, we have different populations, and some of what we're going to show you today shows how we meet the needs of different populations that access unplanned care. A couple of things that are fairly unique to, well, not unique, but distinctive to Lambeth and Southwark is that we have two major specialist trusts. And that's an advantage in a way in that they are just as keen to avoid urgent admissions as we are, because it frees up their beds so they can do their tertiary work, which I think is much more lucrative for them. So we have a good input from them. In terms of the other local issues, St Thomas's and Guy's are both near major transport hubs and railway stations, and that does have a distinct impact on some of the clientele that use our out of the emergency care services, particularly at St Thomas's. And we also, being close to London, to the centre of London, we have a vibrant nightlife, and that also has implications. What do we do as an urgent care network? Well, we act as a forum for all the providers and all the members I talked about to come and share their concerns. We analyse data together. The fact that we have, for example, so although we're responsible for Guy's and Thomas's, the fact that we have our local trusts coming to us, for example, St Thomas's, means that we actually get to understand the other pressures on them from outside other parts of London, which is quite useful. We've analysed, as I said, we analysed data together and we plan together. So, for example, the winter demand review that we've just undertaken was done jointly by all members of the network rather than just particularly from the CCG. The other thing that's fairly unique in London in terms of Lambeth and Southwark, along with Lewisham, is that our out-of-hours provider is provided by a GP co-op, as the GPs in Lambeth, Southwark and Lewisham stayed opted in when the contract changed some 10 years ago. And that does have some distinct advantages in terms of how we get buy-in from the out-of-hours service. And the out-of-hours service has been important in helping us move forward with staff in the various urgent care centres and other initiatives that we've tried. So I'm just going to hand you over now to James, who is at St Thomas's, and is going to talk about one of the programmes, which is the alcohol programme that we've been dealing with.
Thank you. So my name's James Hill. I'm Head of Nursing for A&E and Acute Admissions at St Thomas's, and I've been working alongside Trace Fletcher, who's one of the commissioners, around what is a typical inner city A&E problem, which is alcohol attendances. We formed a partnership last year, just before November, to look at alcohol attendances and look at the pathways, and we did this in conjunction with our King's Health partners. When we looked at the pathway, what we looked at is obviously we get a lot of attendances under the extreme influence of alcohol, but for the purposes of this talk, we're going to talk about drunk people who are off their legs, essentially. We looked at the pathway and we decided that it actually is a medical pathway as it stood in November of last year. So patients came in, they were undressed, they were put into a cubicle. They couldn't sit into the waiting room because generally they weren't able to sit up, let alone, sit and look after themselves. So we undressed them, we did vital signs, we did ECGs, we took blood off them, we gave them fluids, we gave them antiemetics. The relatives then, who were also under the influence of alcohol or drugs, then suddenly see the patients lying on a trolley and think, oh my God, there's something going on here that isn't actually going on. So because they weren't a priority and they were waiting, they generally just had observations done on them until they were seen, and then eventually they were admitted to our emergency medical unit or our CDU. So we sat down and worked out what we could do differently, and so we came up with changes to our model of care, which essentially made it a wholly nurse-led pathway. If a patient is at all unwell or deteriorates whilst we're looking after them, they do rapidly get medical assessment and the right intervention then. As I say, initially the pathway was designed for the drunk off legs patient, but on New Year's Eve last year, those of you who know where St Thomas's is, we are in the middle of the New Year's Eve celebrations. We become an island around the wheel, and so patients are literally wheeled into us. They come by every mode of transport known to man, including fire engines, which is quite amusing. But essentially, what we discovered were there are a lot of people who we could enhance the pathway further, and so patients who'd sort of played with taking some recreational drugs, who just needed some observations, some calming words, and eye cap on them. We were able to enhance the pathway that way. We were also able to look at nurse-led pathways for minor injuries. So we now deal with the drunk off legs, the minor injuries, as well as patients who've taken some recreational drugs. We don't routinely now put fluids and antiemetics up on patients unless they are clinically indicated. And as a result, we have demedicalised the whole pathway for alcohol attendances. What we've seen by doing that is it's reduced, obviously, the burden on the main department. It's also reduced the length of stay for those patients in the department to an average of 90 minutes, whereas before they were 4 or 5 hours, literally just by bringing them in, doing a set of obs on them and a BM ECG if it is indicated. We don't put a line in or anything. We actively encourage fluids every sort of 15, 20 minutes, oral fluids, which is what anyone else who is drunk would go home to bed and do. Essentially, that's what we do with them, and it has reduced the length of stay to around 90 minutes for them. The unintended positive benefits for that, obviously, were we haven't seen any clinical incidents at all, and we have selected the right patients to go through to date. Also, our security incidents have reduced within A&E overnight because we're no longer medicalising it, and people are not coming in thinking, oh my God, there's something wrong with this person. They're actually seeing it for what it is, and we're able to deal with that. And so therefore, we've actually managed to improve the patient journey and the experience overall. So I'll just pass you back to Patrick.
In addition to the population of young off-legs people that James has referred to, obviously one of the other important drivers in our unplanned care are patients with long-term conditions and the elderly frail. Using partners in the network and under the umbrella of the King's Health Partners, which is the Academic Health Science Centre, involving the two trusts, Guy's and Thomas's and King's, the two CCGs, as well as the two councils, we have produced a number of programmes to try and deal with the frail elderly. There are obviously some of them listed up there. The important thing in this working is that we've had advantage of working with the local councils and social services, and they've been particularly important in some of the schemes that we're going to talk about. I'm going to give you over in a minute to Carol Smith, who's the adult community nurse lead in St Guy's and Thomas's, and she's going to talk about two of our schemes, which is the home ward and the enhanced rapid response.
Thank you, Pat, and for the introduction as well. Good morning, everyone. Can you all hear me? Because I'm not very good with microphones. I'm going to briefly share with you two examples we have of working with our CCGs to develop admission avoidance schemes for our local population, primarily but not exclusively around the frail elderly. And those are the home ward and the enhanced rapid response service, which are both home-based pilots. So our aims for both of the schemes were to support early discharge following an acute hospital admission or to prevent admission altogether, and demonstrably to save bed days and reduce length of stay and reduce pressure on acute services. So that was what the schemes were about. And one of the critical things for us was to be able to provide more intensive care at home for people, so that the mainstream services can provide. So, for example, district nursing couldn't provide 4 visits a day per patient, which both of our schemes do. So we were deliberately quite ambitious in the range of schemes that we wanted to pilot to achieve this. So, what have we done? The Enhanced Rapid Response Scheme provides support at home to prevent a hospital admission with a focus on rehab and therapy, and also regaining mobility and functional skills, whereas the home wards provide an alternative to admission and support early discharge. Now, the home wards actually started off as virtual wards, but when we asked patients, they didn't know what that meant, and they also thought that they didn't really exist, which is why we then changed the name to something that was a bit more recognisable and did what it said on the tin, basically. Both services operate 7 days a week, 8 till 11, so not quite 24 hours, but the vast majority of the day and evening, and they both have a 2-hour response time, which is really important for both our A&E and for our GP colleagues. So in terms of what they are, we've got 2 wards of 50 beds in total, and they cover 2 sections of the borough, so not the entire borough, but about 30% of the population in terms of the pilot for the home wards. And that's primarily a clinical service, so it's very nurse-led and nurse-based with a dedicated GP support. And also from pharmacy and therapy, and very importantly for us, with social work support as well, so it's part of that team. And we also have home carers that support that team too, so that if someone is admitted to hospital, if you've got a husband, say, typical scenario is the husband has COPD, but he's the person who looks after his wife, and they both end up being admitted to hospital purely because there's no one at home to look after the wife. We operate in the home ward to make sure that that doesn't happen and that the wife can be supported at home. So that's one of our added values. And the home ward works extraordinarily closely with the Enhanced Rapid Response team. That covers both boroughs, and that also has support workers, therapy and nursing with some specialist medical support. And the difference between the two is that Enhanced Rapid Response is very much more around therapy support and social care, but the two very much linked together. So what have we learned from our pilots from just about over the year in which they've been operating? We did have a lot of teething problems, especially around things like communications and IT, which is not unusual for projects, but particularly projects working across different hospital systems and community systems. We did an early evaluation at about 6 months and expanded that at 12 months. And the key things that we found were that it was really well received by both clinicians and by patients, importantly. And the majority of clinicians signed up, and actually just talking at our last session, we just recognised that actually we had a 100% score in our first pilot ward, which took a little while to get there, but it did in the end. So we had to prove our case to some clinicians, but we did so. And in terms of the patient experience and what patients are telling us about what they thought about the service, they really liked the quality of care. They were really that was very key to them. They liked being in the place of their choice. They wanted to be at home and not in hospital. They really liked the idea of joined-up services. They liked the idea that we were coming to them and not expecting them to come to us. They liked the continuity of having a service that stretched across health and social care. And they really liked the idea that we could prevent their next admission. And so one of the unintended benefits for us was that patients started ringing us up and checking whether they should be going to A&E or whether they should come to the home ward. So we were actually generating some business that way too. So that was helpful for us. So in terms of just some hardcore numbers about performance, in terms of our bottom line, the services are now very well used. We get around 50 to 100 referrals a month. And this is bearing in mind the home wards cover 30% of the population, so that's significant activity for us. Each service has had well over 1,000 patients, so we've got a bit of a base to work from now. We've had far more women than men, so in line with our local population demographics. But we've had roughly equal referrals from GPs in terms of the admissions avoidance elements and preventing people going in, and the hospital avoidance, that is getting people out of hospital quickly. And in terms of the last home ward audit that we did an audit of 50 patients and we saved 284 bed days. Inpatient bed days, I should say, or around 5.6 bed days per patient as an average. So that's helpful in terms of understanding what impact we're having. And in terms of our next steps, what our long-term strategy is, expanding the service to across the entire borough when it comes to the home ward, so that all practices can refer in, and hospitals don't need to think about which patients they refer, to make it really easy. So, and we're projecting around 3,000 to 4,000 referrals over the next per year in the next 3 years, and a saving roughly of about 23,000 occupied bed days. So some significant savings in terms of the schemes, and we're looking to build on our initial successes and to get it up and running in time for winter pressures. And that was our discussion this morning. Thank you.
So what we were hoping to do is just give you a flavour of just using 2 examples of the work we do through our urgent care network, and we could have picked many other things. So work with mental health, work with in terms of some social marketing with our patients, work on primary care in terms of access and so on, work within the hospital setting as well about their pathways and so on. We could have picked a whole range of things, but we wanted to give a flavour of the fact that it goes right back to Anne's first point at the very start of the day. You've got to think about your population, you've got to think about their population needs, and you have to meet those needs in a variety of different ways to achieve the best outcomes. So what you've seen in those 2 examples are 2 very different populations requiring a different approach from the urgent care system, not just individual providers within it. And that's what we try to do. It's also appropriate to end on a kind of learning slide, because we're still learning as we go along. So Pat started off saying we've been around for a decade as an urgent care network, and we've gone through all sorts of different membership and guises and problems to challenge. But we're a learning network. And you just heard now about we're rolling out this and we're looking to push some of the boundaries on integrated care. That's not to say we'll have got it 100% right in any of our implementations. So we work on a rule of 80-20. And we have to keep learning and keep improving and checking out, not just with our patients, clearly they are our number 1 people to tell us whether we're getting this right, but also with our clinical teams as well.